right. Good evening, everyone. Can you guys hear me okay? All right. I see a few people are joining, so let's give one more minute and see. All right. So I think we can go ahead and get started. You guys see my screen okay? Yes. All right. Okay. So welcome everybody to our SSAT High Yield Topics with ABSITE 2025. This is the second part. The first part happened in December. So we're excited to have Dan, Gilbert, and Bailey to help us with our ABSITE review session today. My name is Wilson Alobi. I'm one of the computational surgical oncology and HPB fellow here at The Ohio State University, and I'll be the moderator for today's webinar. Just a quick plug for the SSAT's membership. So as residents and trainees, as you can see here, we qualify for the reduced discounted rate for membership. So I would encourage everybody to go onto the SSAT website and looking to becoming a member because it has quite a few benefits. So as part of your membership, you get access to the Journal of Gastrointestinal Surgery, pretty high rated journal that is very useful for all things GI. And you also get deeply discounted elite buried registrations for the conferences, the SSAT conferences and Digestive Disease Week. You also would have the opportunity to be able to apply for awards and grants and other funding opportunities, including travel fellowships that a lot of people have found useful and have taken advantage of. And there are also several opportunities for leadership as part of our everyone's professional development. There is a special, very, very special and dedicated area on the SSAT website that is dubbed the Residence Corner. If you go on the SSAT website, you should be able to you should be able to access it, or you can just follow the link here, www.wsat.com/residence, and that takes you to that very special webpage that is dedicated to all things residents and fellows. For today, I would like to thank Gilbert Marimois and Dan Stoltz and Bailey Johnson for joining us and helping with our high yield topics review for today. Gilbert is a resident at UT Southwestern, and he will be helping us today with the hepatobiliary section. Dan Stoltz is a resident at Stanford, and he'll be helping with the colorectal section. And Bailey is a resident over at Indiana University and should be doing the breast section. So thank you, Dan, Gilbert, and Bailey for taking the time and helping us today. And just a reminder that there are several webinars and recordings that are available on the SSAT website, including the recording from today's session. That will be uploaded to the website, I believe, in the next 24, 48 hours or so. So you can feel free to go back and rewatch the videos. And if there were any questions that came up and you just need some clarification about anything else, you'll be able to go back and replay these recordings. Similarly, there is a dedicated SSAT YouTube channel, which is where this webinar will be posted, that has several other important or useful recordings, like the SSAT podcast that has attending surgeons and different people from different walks of life in surgery come talk about different things, not just surgery, but all things surgery related, lifestyle, well-being, all these other things that are all available through the SSAT podcast. So certainly something to also check out. So if you have not bookmarked the SSAT YouTube channel yet, this would be a good opportunity for you to do so because there are several opportunities for education. So to wrap up, I would like to acknowledge, like I said, Bailey, Gilbert, and Dan for taking the time to help us today, and the SSAT for organizing this to start with, as well as the SSAT Resident and Fellow Education Committee that is responsible for organizing and making sure that we are providing things that are helpful for all AACT trainee members. And special thanks to Dr. Narayan Raja, who was in my shoes last year and was the emeritus moderator for these sessions. He's currently now an assistant professor at Loma Linda. And obviously, Bev, who is on the call with us, she's the AACT Director of Administration and has been tremendously helpful in organizing this session. So thank you so much, Bev, for helping and always supporting us. So without further ado, I think the order today is we're going to start with hepatobiliary. So Gilbert Lemoy is going to go first. I'll stop sharing my screen.
Awesome. I'll share mine. Let's see.
And before Gilbert starts, just a reminder, please feel free, there's a Q&A tab at the bottom. Please feel free to enter any questions you may have to the chat. And I'll bring all those, I'll be monitoring the chat and I'll bring those up at the end of each presenter's session. So please feel free to put in some questions.
All right, I'll get started. Thanks for the introduction, Wilson. I'm Gilbert Murmur. I'm a PGY6 at UT Southwestern in Dallas, and I'll get to talk to you guys about the best topic of the day, hepatobiliary disease. Already got ahead of myself. So we'll start with a little bit of liver anatomy. Here we have an anterior and a posterior view of the liver. You've got the inferior vena cava, which passes behind the liver, as well as the aorta, frequently seen as falciform ligament, which terminates at the ligamentum teres. And you'll see kind of on the posterior view, some key landmarks are the portal vein, the common bile duct, the proper hepatic artery, and then the caudate process, as well as some ligaments that we'll cover as well. And so, nuanced things about liver anatomy, there's lots of hepatic artery variants. The right hepatic artery typically comes off of the SMA in 20% of patients, which is the most common variant. This is called a replaced right hepatic artery. And it courses behind the pancreas and posterior lateral to the common bile duct. And so, this is something frequently people look for when doing a cholecystectomy, because if you're not careful, you can run into that common variant. Another common variant is a replaced left hepatic artery, and this is when it arises from the left gastric artery. Again, this is present in about 1 in 5 patients, and this is where you could typically find this vessel in the gastrohepatic ligament medially. The falciform ligament separates the medial and the lateral segments of the left lobe. It attaches the liver to the anterior abdominal wall, and it extends all the way down to the umbilicus and carries the remnant of the umbilical vein. We mentioned ligamentum teres as well. And then a line that's very commonly referenced if you're planning for liver surgery is Cantley's line. And this is a line where if you draw from the middle of the gallbladder fossa to the IVC, it separates the right and the left lobes of your liver. And so the liver actually has 8 segments. Segment 1 is the caudate lobe. Segment 2 is the superior left lateral segment. 3 is the inferior left lateral segment. And then you've got segment 4, which is actually divided into 4A and 4B. This is the quadrate lobe, if you will. And then segment 5, 6, 7, and 8 are seen on the right side of the liver, making the anterior medial, the posterior lateral, and then the superior and inferior components of each of those segments. Glissen's capsule is the peritoneum that covers the liver, and you have a bare area on your liver, which is the posterior and superior surface that's not covered by Glissen's capsule. The triangular ligaments are lateral and medial extensions of the coronary ligament, and they're on the posterior surface of the liver, and this is just kind of where the peritoneum folds up on itself. The portal triad, as we mentioned earlier, enters segments 4 and 5, and then the gallbladder lies just under segment 4 and 5 as well. So more specifically about those ligaments, you'll see here a visual representation of where the bare area of the liver is. And then you've got your left triangular ligament, the posterior and anterior folds of your coronary ligaments, the right triangular ligament, and then the coronary as well on that side. And then you'll see where falciform extends kind of along the anterior and superficial edge of the liver there. The left, right, and coronary, as well as the falciform, attach the liver to the abdominal wall, while the round ligament, also known as ligamentum teres, connects the liver to the umbilicus. Again, this is the obliterated umbilical vein. And so when planning for liver resections, this segmental anatomy is really important for talking about what you're going to be resecting. You can do anything from a segmentectomy or a left extended hepatectomy, a left hepatectomy. These are kind of seen over here. And really, it's composed of what liver segments you're taking. And this is all based off of the venous supply and anatomy of the liver. One thing that you need to take into account when doing kind of these formal liver resections is something called the future liver remnant, and it's the volume of the liver that remains after resection. This is predictive of the likelihood that a patient's going to go into post-hepatectomy liver failure, which is one of the most feared complications after big hepatectomies. Now, patients who have normal liver parenchyma, they haven't had any chemotherapy, they're not cirrhotic. Typically, all a patient needs is about 20% of their future liver remnant, but depending on other comorbidities like chemotherapy or cirrhosis, you may need as high as 30 or 40% to really feel good about the idea that after a resection, you're not going to put your patient into liver failure. Now, one method of expanding the liver's future volume is portal vein embolization. And this really relies on the fact that the liver gets blood flow both from the portal system as well as the arterial system. And so, portal vein embolization is when you embolize the right or the left portal vein, and it allows hypertrophy of the contralateral side to where your tumor is. Now, this is an image that shows a sample operative plan where a patient has multifocal disease both on the left and the right side of the liver. And you can imagine a system where in the first operation, you wedge out a little bit of disease on the left side of the liver, kind of clearing that side of the liver of all disease. You then perform this portal vein embolization and allow time for the future liver remnant to expand on that side that has now been cleared of disease, restage your patient with imaging studies and scans, recalculate their liver remnant, and because of the liver's ability to regenerate itself, you can now go on for a second stage operation where you do an extended right hepatectomy after giving some time for that left side of the liver that is now clear of disease to hypertrophy and enlarge. Now, switching from some liver anatomy and planning, we want to talk about cirrhosis and portal hypertension or pathology of the liver. And so a key thing to know is the hepatic vein pressure gradient, and anything over than 6 millimeters of mercury is diagnostic for portal hypertension. It's important to know that this is a wedged pressure, and so it's actually reading the free hepatic vein pressure, similar to what you would do with the Swan-Ganz catheter, but in the liver in this instance. And essentially, it's the pressure gradient between your portal vein and the vena cava. Hypertension in the liver is separated into pre-sinusoidal, sinusoidal, and post-sinusoidal, and these are all really based on what is the cause of this hypertension. Things like schistosomiasis cause pre-sinusoidal hypertension, things like cirrhotic states, hepatitis, intrinsic liver disease, that's causing pressure in the sinusoids, and then things like Budd-Chiari or portal vein thrombosis can cause post-sinusoidal portal hypertension. Varices really occur anywhere where the splanchnic circulation meets the systemic drainage. And so if you've got distal esophageal varices or proximal stomach varices, that's because that's this splanchnic bed that's kind of getting increased pressure. You see pressure in the umbilical system causing caput medusae, pressure down in the rectal system causing hemorrhoids, and then you can also get retroperitoneal varices, but those typically aren't seen with any visualization. Now, important scores for kind of moving through the severity of cirrhosis in patients are the MELD score and the Child-Pugh score. MELD uses creatinine, bilirubin, INR, while the Child-Pugh system uses bilirubin, INR, albumin, and then the presence of ascites encephalopathy. These scores are useful to know when you take the ABSITE because frequently they'll kind of help you decide how sick and how significant a patient's cirrhosis is and what interventions may be warranted or necessary. Now, the mainstays of management are beta blockers for prophylaxis, especially for patients with varices. Vasopressin and octreotide, because of their activity on the splanchnic beds, can also help in settings of acute cirrhosis. Once patients have GI bleeds, MTP is important. Blakemore in Minnesota drains that tamponade off that variceal bleeding are also mainstays of therapy, and then Protonix drills as well as endoscopic banding are necessary. And then for your patients who have encephalopathy, rifaximin and lactulose help clear the ammonia out of the system and help compensate for some of those side effects associated with end-stage and severe cirrhosis. TIPS procedures are used to decompress the portal system, and so they can be helpful for variceal bleeding, but it's important to know that they're going to bypass the filtering capacity of the liver and thus exacerbate any encephalopathy patients may have. So now we'll transition over to infectious liver diseases. One of the most common questions on ABSITE typically is pyogenic liver abscesses, and sometimes there'll be images, sometimes there'll be a prompt that kind of leads you down this thinking, but most pyogenic liver abscesses involve the right hemiliver. This is true in about 75% of cases. Half of all of them are solitary, And then these abscesses tend to be polymicrobial. And so GNRs are almost always present. You'll see things like E. coli, K. pneumoniae. Those are the most common pathogens, but typically you'll have a mixture of pathogens that are causing these pyogenic liver abscesses. Patients will present with fever, jaundice, right upper quadrant pain, and tenderness. That tenderness is kind of from the pressure buildup from a distended liver capsule, as you could see in the CT scan. These abscesses kind of occupy large portions of the liver and cause symptoms that way. On CT scan, you'll see an enhancing abscess wall. Then the mainstay of treatment is antibiotics as well as IR drainage of these abscesses. You can also have amoebic liver abscesses. These are more common in tropical and developing countries, places where you may not have well-established water sources. And Entamoeba histolytica is the most common cause of these. There's a 10-to-1 male to female predominance, and humans are the main host as well as the main source of infection here. These infections are really caused by fecal-oral transmission of the Entamoeba cysts, and the liver abscesses form by progressing, causing localized hepatic necrosis, and then produce a cavity within the liver where they build up this acellular proteinaceous debris. And that's why when you look at the CT scan, they look to be homogeneous within the actual cyst itself. The abscess fluid looks like anchovy sauce is the kind of buzzword characteristic description. This is really a mix of blood as well as liquefied liver tissue. Most of these present in 20 to 40-year-old men. Again, they'll have fever, chills, anorexia, that right upper quadrant pain, and then hepatomegaly and tenderness. When it's caused by Entamoeba histolytica, it's important that you use antibodies with activity against that specific antigen, and so you need anti-amoebic antibodies to be developed. And then you can treat with flagell and drainage of the abscess if it's larger than 5 centimeters. Now, a different type of abscess is caused by echinococcal cysts. So these, unlike the amoebic abscesses, are really come from dogs and sheep, dogs being the main host of these cysts, and then sheep being passerbys. And so some exposure to those zoonotic animals and carriers is typically common for patients who get this presentation. And so the most common echinococcus are granulosus and multilocularis and Ligardis. Ligardis is less common, but you can see any of the echinococcal strains kind of causing this presentation. Now, the cysts can form what are called daughter cysts, and this is where you may have calcifications that are separating multiple cysts within a larger cyst. There's two CT scan images on screen right that kind of highlight this phenomenon and how severe and advanced disease may present and look. There's no male or female predominance for this, and typically this happens 5 to 10 years after the actual exposure to the echinococcal cysts. Again, 75% are in the right side of the liver, and these are typically solitary. And then when you have free rupture, which is one of the feared complications, you can actually get disseminated echinococcosis or anaphylaxis, a big reaction to the echinococcal um, parasites that are within these cysts. The treatment here is albendazole or mebendazole, and it's effective at shrinking the cyst, but it's very rare for the cyst to completely go away, and sometimes surgical resection is actually warranted, again, with careful planning to not rupture or spill any of the contents of these cysts. And for large or complex multicystic lesions that are not amenable to surgery, there's this PAIR acronym, which is puncture, aspirate, inject, typically with something like ethanol, and then reaspirate. And the idea is you're trying to clear the pathogens that are within the cyst without getting any of them to trigger that anaphylactic reaction. We'll now move on over to liver neoplasms, the first of which we'll start with are the malignant liver neoplasms. And so metastasis are your most common liver tumors that you're going to see in patients, with the 20-to-1 preponderance, most commonly being from colorectal cancer. Hepatocellular carcinomas, sometimes called hepatomas, are the most common cancer worldwide. And these are typically seen with symptoms of right upper quadrant discomfort, weight loss, and the main risk factors and the reason why it's the most common cancer worldwide is hepatitis B. Hep C is also a known risk factor, alcohol use, hemochromatosis, alpha-1 antitrypsin deficiency, as well as PSC, aflatoxin from mushrooms, or presence of hepatic adenoma, steroids, pesticides. These are all things that can increase the risk of developing hepatocellular cancer, but hepatitis B is by far the most common cause worldwide. There is a fibrolamellar subtype typically seen in adolescents and young adults, and this carries a better prognosis. And then a diffuse nodular subtype is a much worse prognosis. And so some detail there between the types of hepatocellular cancer, but knowing those two, that one has much better prognosis and another one is much worse, is important. AFP levels for these tumors correlate with the tumor size, and the 5-year survival rate for patients that actually get surgery is as high or as low as 30%, depending how you look at it. There's very few tumors that are resectable because of cirrhosis. And if they have portohepatic lymph node involvement or metastasis, that really drops the percentage of patients who have resectable disease down to about 15%. Important to know with margins, especially for ABSITE, you want a 1 centimeter margin around these lesions, and then recurrence is the most likely to occur in the liver after resection. So these aren't tumors that typically pop up with lung mets or mets somewhere else. Most of the time when patients recur, it's going to be back again in that liver parenchyma. A less common liver cancer is hepatic sarcoma, PVC or polyvinyl chloride. This is a environmental agent sometimes used depending on people's jobs that has a risk factor of causing hepatic sarcomas. And then there's things sort of known as thorotrast as well as arsenic that can be rapidly fatal and cause disease progression here. Now, if you have isolated colon cancer with mets to the liver, depending on your future liver remnant and other comorbidities of the patient, you can actually resect these and extend survival significantly for patients. So this is the one few areas where there's oligometastatic cancer that really does benefit from resecting metastatic lesions. The 5-year survival rate after resection for those patients is as high as 35%. And again, this is in a metastatic setting, so that's pretty significant. Now, primary liver tumors are typically hypervascular, while metastatic liver tumors are generally hypovascular. And there'll be a table later on that helps you tease out the difference between some of the different liver lesions you'll see. Now, focusing on two of the more common liver neoplasms, focal nodular hyperplasia and hepatocellular cancer, you can see that focal nodular hyperplasia is the second most common benign tumor of the liver. It's got this characteristic central fibrous scar with radiating septae. That's the characteristic finding that you'll see when you kind of look at your imaging for these. And histologically, there are cords of benign appearing hepatocytes and bile ducts, and that's what's making that radiating septae. Again, you can see some of the buzzwords here. These typically have rapid arterial enhancement. They go from hypo to iso enhancing on the portal venous phase, and the scar may enhance on delayed phase imaging. If you use EOVIST, which is an MRI contrast, these are the only lesions that will enhance using EOVIST. And so that's an important key to discriminating between the two. And then focusing on hepatocellular carcinoma again, as previously mentioned, this is the most common primary malignant neoplasm of the liver, largely due to hepatitis B. These are intensely arterial enhancing, again, because they get their main blood supply from the hepatic arterial system. And they'll have rapid washout on imaging. They're hypoattenuating on delayed phase. And the mainstay of treatment is resection or liver transplant. This is where the Milan criteria comes into play. And so for ABSITE, it's really important to know if you have one lesion less than 5 centimeters or up to 3 lesions that are less than 3 centimeters each without any extrahepatic disease or vascular involvement. Those are the criteria for patients to be considered for liver transplant. This is a busy but large table on MRI characteristics of some of the most common lesions, hemangioma, focal nodular hyperplasia, and adenoma, HCC, intrahepatic cholangiocarcinoma, and metastasis. So you can work through here and see some of the differences between the lesions. Under focal nodular hyperplasia, you can see here that central stellate scar there, the radiating septae. This is kind of characteristic for that lesion there. And then anytime you get an MR abdomen specifically for the liver, you're making sure to get an arterial phase, a portal venous phase, and a delayed phase, because that's really what's going to help you differentiate the difference between all of your lesions. Now, moving away from cancer to biliary colic and cholecystitis. Biliary colic is the transient blockage of the cystic duct, and that causes pain as the gallbladder gets kind of distended. That distension causes the pain, and that's what patients typically present with. Now, that can be caused by stones in the gallbladder or acalculous causes, which are a subtype of functional gallbladder disorders. But sometimes patients actually develop chronic cholecystitis where they have recurrent attacks that lead to a chronic inflammation of that gallbladder. Tokyo guidelines are a way to kind of grade the cholecystitis from mild to severe. And the mainstay of diagnosis is ultrasound and HIDA scans. You need to have normal liver function for the HIDA scan to be accurate, but the ultrasound is typically Diagnostic if you see things like pericholecystic fluid, an impacted stone in the gallbladder neck, or a thickened gallbladder wall that's greater than 3 millimeters. You can't give a talk that involves cholecystitis without the critical view of safety. And so you'll see here the underside of the liver. This figure's from a paper, the gallbladder here. And really you want to identify the hepatocystic triangle as well as Close triangle. In real picture here, you'll see this is Close node over here. You've got your cystic artery, you've got your cystic duct, and then its entrance into the common bile duct down here. And then your other portal structures are more medial with the hepatic artery over here. The whole goal of a cholecystectomy is to safely dissect out the cystic duct as well as the cystic artery and see only those two structures entering the gallbladder so that you avoid injury to your portal structures or potentially even a replaced right artery, which of course lateral to here, which is a bit abnormal. But this is some real anatomy to kind of get an idea of those critical structures. Now, gallbladder polyps and their risk of cancer really depend on the size of the polyps. And so polyps that are less than 6 millimeters, there really aren't very good guidelines on them. People typically don't surveil these, just kind of make note of it in your ultrasound or radiographic report. Once they're above 6 millimeters, up to 9 millimeters, this is the prime area for surveillance. Really, we're looking for risk of cancer. And so most recommendations are 6 to 12 months for serial imaging and surveillance. And then once a polyp is greater than 1 centimeter, that is an indication for surgery. So those are patients that you're consenting and offering cholecystectomy for. And then if anything is bigger than 18 millimeters up to 2 centimeters or larger, you really need to be concerned that this patient may already have gallbladder cancer. Risk factors for gallbladder cancer include that chronic inflammation we talked about. Porcelain gallbladder is still listed in a lot of references as a risk factor for gallbladder cancer, but this is less common now. There's more and more data that suggests that there really isn't a strong association between the two. But certainly polyps that are greater than centimeter, patients who've had primary sclerosing cholangitis, and then typhoid, these are all risk factors that increase the chance of having gallbladder cancer. Treatment really depends on the staging of this. So whether if you have T1A, which means the tumor invades up to the lamina propria, cholecystectomy is all you need. Don't spill, don't get into the gallbladder, but just take it out, and that's definitive therapy for patients who have these early stage small lesions. But once you have T1B disease, which means that the polyp is invaded into the muscularis layer of the gallbladder, you need not only a cholecystectomy, but also a formal segment 4B and 5 resection. Again, 4B and 5 are the segments of the liver where the gallbladder fossa lies. So removing those in addition to the gallbladder and then doing a proper lymphadenectomy is important for both staging prognosis and deciding treatment thereafter. Now, gallstones cause things like choledochal lithiasis, which is when the stone is stuck in the common bile duct, cholangitis, which is infection and inflammation secondary to that blockage, and then Maritzi syndrome, which occurs when a bile duct is obstructed not intrinsically by a stone, but compression from a stone within the cystic duct. We saw earlier in the picture, let me see if I can pull it up. Here, if you have your cystic duct and it's entering onto the common bile duct, in a Maritzi syndrome, you'll have a stone lying somewhere here within the cystic duct that pushes down and onto the common bile duct, and that's what actually causes the inflammation in the Maritzi syndrome. Gallstone ileus is a frequently tested topic, and it's when you have obstruction of the intestinal lumen from a stone that fistulized from the gallbladder itself into the duodenum, and this commonly occurs in the distal ileum where the ileum tapers off and the stones typically get stuck. The mainstay of this is these are typically chronically developing processes, mature fistulas between the gallbladder and the duodenum, and so the management is to take the obstruction first. Typically, this involves making an enterotomy, milking the stone proximally until you can fish it out. That relieves the obstruction. You repair your enterotomy. You typically leave the gallbladder alone. Do not take it out during the index admission or operation. You can consider taking it down the road, but frequently these also just kind of get left alone. Gallstone pancreatitis kind of finishes our sequelae of gallstone disease, and this is managed with ERCP or intraoperative cholangiogram, and then cholecystectomy is indicated during the same admission. Now, biliary dyskinesia is a subtype of gallbladder disease, and this is truly a motility disorder of the gallbladder. Again, HIDA is the diagnostic modality of choice for this, and you're looking for an ejection fraction less than 30 to 35% coming out of the gallbladder to diagnose biliary dyskinesia. The Rome criteria, which is used for functional disorders of the gallbladder, You can read it here below, but this is a criteria that helps you diagnose someone and decide whether or not you really think that they may have biliary dyskinesia and not some other vague abdominal pathology going on. Now, colorectal cysts are another favorite of the ABSITE. They're anomalous pancreatico-biliary junction that allows reflux of pancreatic secretions back into the bile duct, and this causes inflammation and damage to the biliary tree. There's five types of these. Type 1 is what happens in 90 to 95% of cases. This is a fusiform solitary dilation of the common bile duct and the hepatic duct. Type 2, which is pretty rare, is a cystic diverticulum of the common bile duct. Type 3 is a choledochal. Type 4 is where you have combined dilation of the intra and extrahepatic biliary tree. This is second most common. And then type 5 is Crowley's disease, where you have a single or multiple intrahepatic cysts, but really have not developed any bile ducts whatsoever. This is diagnosed with imaging most of the time, ultrasound, ERCP, and MRCP, potentially even a role for a HIDA scan. And the surgical management depends on where the choledochal cyst is actually found. Type 1s are treated by a complete surgical excision of the cyst, cholecystectomy, and then a Roux-en-Y hepaticojejunostomy. Type 2 are treated with a diverticulectomy. Type 3 are treated with a sphincterotomy. Type 4 get resection or transplant. Then type 5 is managed either conservatively with biliary drainage procedures or with actual hepatic resections, transplants, and otherwise. It's important to know that type 1 and type 4 carry a malignancy risk. This is a visual representation. So again, you could see type 1 is this fusiform dilation, the most common. Type 2 is a true diverticulum. This is fairly rare. Type 3 is a choledococele. Type 4 is the multiple. You have intra and extrahepatic dilation. And then type 4b is where you have multiple extrahepatic only without intrahepatic, but that's more nuanced and kind of in the weeds, unlikely to be on the ABSITE for you. Now we'll transition from liver pathology to pancreas. And so pancreas anatomy, you've got the head, the uncinate, the neck, the body, and the tail. The head and uncinate are supplied by superior vessels that come from the GDA along the celiac axis, and then the inferior pancreaticoduodenal arteries branch off of the SMA. The neck, body, and tail are supplied by the splenic artery, which runs posterior to the pancreas, and this is where the dorsal and greater pancreatic arteries arise. It's important to know that the neck of the pancreas here lies anterior to the SMA and the SMV, and then the SMV and splenic vein actually drain the majority of the pancreas. You can see some of the surrounding anatomy in this image down here. Acute pancreatitis is the first pathology of the pancreas we'll cover. Gallstone pancreatitis is the most common cause of acute pancreatitis in the West. Smoking and alcohol are more likely to cause acute pancreatitis, and is that the two of them are additive to each other in the risk. Now, anatomic obstruction from things like pancreas divisum, annular pancreas, Ascaris infection, those can also cause pancreatitis just from that poor drainage of the pancreatic system and the backflow and pressure. ERCP, this is one of the most not feared, but a common complication of ERCPs is post-ERCP pancreatitis. And so always be astute to that after a patient undergoes a procedure. And then several drugs are also known to cause pancreatitis. Familial hypertriglyceridemia is a very common cause of pancreatitis. You should be suspicious in patients who have triglycerides above 1,000. And if it's over 2,000, it's almost diagnostic and confirmatory that that is the source of the pancreatitis. Hypercalcemia causes an activation of trypsinogen in the acinar cells, and this can also cause pancreatitis, as well as genetic syndromes that involve PRSS1, CFTR, which is cystic fibrosis transport receptor, and then SPINK1 as well. Here's a nice diagram that covers some of the causes as well as sequelae of pancreatitis at the bottom. Now, it's important to know the revised Atlanta classification system for the test. And so when you have a patient with acute pancreatitis, this is going to be an imaging CT-based criterion. And so you want to look for normal or minimal enhancement of the pancreas or reduced enhancement. This will help you go down the branch point of, is this interstitial edematous pancreatitis or is this necrotizing pancreatitis? The next step along the kind of workflow is when patients have fluid collections. If those fluid collections are within 4 weeks of the bout of pancreatitis, they're called acute peripancreatic fluid collections. And then after 4 weeks, they become pseudocysts. Now, if the patient initially had necrotizing pancreatitis, these are called acute necrotic collections versus walled-off necrosis. Really, one of the main keys for this is it's important for your management down the road on when you need to place drains with IR, when you need to activate the step-up approach, and then way down the road when patients are indicated or not for things like VARD procedures. Now, pseudocysts are one type of pancreatic cyst, but there are also multiple cystic neoplasms of the pancreas and cystic lesions of the pancreas. And so you always want to start by asking the question, is there mucin in this cyst? And this is typically done with an EUS guided aspirate. You look at the cyst fluid, and if the CEA is high, you know that this is a mucinous cyst. If the CEA is low, then it's a non-mucinous cyst. The next question you want to know is, does this cyst communicate with a duct? Amylase should be found within your pancreatic duct. And so as you'll see down here, if you have high CEA, low amylase, this is a mucinous cystic neoplasm. Those are not communicating with the pancreatic duct, but are containing cystic or mucinous fluid. And these are typically resected because of their malignant risk. IPMNs are next on this branch point. They both communicate with the pancreatic ducts, high amylase, as well as contain mucin, high CEA. And there's a whole criteria that we'll go over that kind of covers when you resect these, when you observe them, and when you don't do anything about them at all. We just covered pancreatitis. This is a pseudocyst, so it's high in amylase because it came from communication with the pancreatic duct. We think that that was disrupted in the episode of pancreatitis, but the mucin is low in this, and so there's no CEA present in the aspirate. You also have serous adenomas, solid pseudopapillary neoplasms, and PNETs. These are all going to have low CEA, but may have high amylase in the case of pseudocysts, or low amylase in the case of these three lesions down here. Now, specific to IPMNs, these are frequently diagnosed incidentally on imaging done for other reasons. The Kyoto guidelines have given us kind of an idea of how to manage these patients, how to surveil these patients. The idea being we want to prevent the development of cancer or identify it early. And so the mainstay of this guideline is you need either an MRI or MRCP, and you need an EUS for further assessment if you have suspicious things. And so there's what's called high-risk stigmata. If you have any of obstructive jaundice, enhancing mural nodules that are larger than half a centimeter, main pancreatic duct dilation above a centimeter, or suspicious or positive results on cytology, this would be from an EUS. These are all reasons to counsel that patient on surgery and plan on going to the operating room. Now, if you have worrisome features, this is where kind of clinical gestalt and decision-making comes into play. You have to go through this workflow and kind of decide how high is the risk based on previous pancreatitis, CA19-9, new diabetes that's recently been found, cyst size greater than 3 centimeters, mural nodules that are maybe smaller than half a centimeter, thickened septations within the cyst. All of these worrisome features, as they add up, they're increasing the risk that this IPMN may have malignant potential and may be more likely to progress to cancer. And so the Kyoto guidelines, if you look them up, it gives you a nice flow chart that kind of works through how and when to surveil patients, how long to surveil them for, and when you can even stop surveillance if they don't have concerning features, take them completely off. Functional PNETs, this is a table just to know for the ABSITE, rarely seen but frequently tested topics. Insulinomas are the most common functional PNETs. Gastrinomas are the most common in men 1. And then you can see the location of these lesions, the hormones they produce, as well as kind of their presentation and diagnosis. One that I've seen on several ABSITE tests, glucagonomas and the 4Ds, dermatitis, diabetes, depression, and DVTs. These are very frequently seen, as well as Whipple's triad, the WDHA syndrome with VIPomas. And so this is a table to just spend some time on before the test and really internalize into your mind. And then last but not least, we'll touch on pancreatic cancer. This presents as painless obstructive jaundice. Tumors in the body and the tail frequently have pain and weight loss as their most common symptoms. This is because they don't immediately impinge on the duct, and so you don't get that jaundice right away. New onset diabetes is a very worrisome finding in an adult person who presents with some of these symptoms. And then just things that show up on tests sometimes. Virchow's node is a left supraclavicular node. Sister-Mary-Joseph nodes are periumbilical lymphadenopathy. Bloomer shelves are a sign of peritoneal dissemination. And then Courvoisier sign is painless palpable gallbladder due to biliary obstruction. And so these are all kind of constellation of symptoms you may see. This CT scan kind of highlights you'll typically have a mass in the head of the pancreas. You'll have distal dilation of the pancreatic duct, sometimes with associated atrophy. And then the common bile duct can be dilated because of a periampullary mass or mass in the head of the pancreas that's kind of obstructing on the bile duct before it gets to the ampulla as well. And so these are frequently things to kind of look for in CT scans when diagnosing pancreatic cancer. And then treatment really is based on the resectability of lesions. If you have localized and resectable disease, this is based on arterial as well as venous involvement. These patients can get upfront surgery as standard of care. In some centers, they do neoadjuvant therapy as well. But for the ABSITE, I think it's completely reasonable to take these patients straight to the operating room. You also have borderline resectable disease and locally advanced disease. Really, this is how much arterial and venous involvement there is. So if you have less than 180 degrees of involvement, it falls into this borderline resectable category. These patients get fulvestrant or gemabraxane. If you have more than 180 degrees of involvement, that's locally advanced disease. These patients are not thought to be surgical candidates at any point, and need chemotherapy and sometimes radiation as well. But your management is really dependent on the resectability criteria for each stage. This is not a comprehensive review of HPP disease. This is a talk that can go on for hours. But thank you, good luck, and we'll answer some questions here at the end.
Thank you, Gilbert. I think there's one question, and just FYI, there's a poll that Bev just sent out. So if you don't mind, please fill out that poll. There was one question about if we need to know the Kyoto guidelines for the apps. I imagine this is regarding the app site. I don't think that the Kyoto guidelines are really tested necessarily. It's something that is important to know clinically in the management of patients with IPMN, mostly for surveillance. Patients that you've been following for some time, and they begin to show some of these signs on imaging, and that's when the bell should go off about sort of, do I keep following, or is it time to operate on these patients? Um, so, and correct me if I'm wrong, but I don't think you need to know the Kyoto guidelines necessarily or memorize that entire chart necessarily for that site. The two things that I think were very important that Gilbert mentioned were the choledochal cysts, certainly very, very commonly tested. So what I found to be helpful is seeing a picture of it many times, and that helps you determine what to do for them because you know where the lesions are, and that helps you understand what kind of operation to offer the patient. So if you were to memorize anything about choledochal cysts, it would be getting one good picture and memorizing that. And then gluconomas, like Gilbert said, very frequently tested as well. All right. There's another question said, is the Kyoto guidelines only for branch duct IPMNs? Because I think you always resect main duct IPMNs. Please correct me if I'm wrong. That's correct. So yes, main duct IPMNs you're going to resect because of their high risk of pancreatic cancer. Branch duct IPMNs are what we typically will observe over time. Yes. So mostly Kyoto guidelines typically are for branch duct IPMNs that you're observing. All right, we'll move on to Dan. So Dan, feel free to share your slides.
All right. Can you see the slides okay?
Yes.
All right. So I'm Dan Stoltz. I'm a general surgery resident at Stanford University going into colorectal surgery next year. So just to start out with some colon anatomy, we'll start with the normal layers of the colon. So starting on the internal surface, of course, you have your mucosa, followed by your thin layer of muscularis mucosa. Beneath that, you have the submucosa, followed by the muscularis propria. Then you have your subserosal adipose tissue and your serosa. I know this doesn't sound like it's worth memorizing, but if you take this into account, this is kind of how questions are typically phrased to get your T staging. And it's relevant for a lot of portions of the GI tract. So I think it is helpful to correlate these histologic layers with your T staging because it helps you connect the question to what the treatment for that particular stage is going to be. Going through some arterial anatomy of the colon. So the colon is supplied from two arteries off of the aorta, of course, your SMA and your IMA. So your SMA will give off the ileocolic artery, which supplies your terminal ileum, appendix, and your cecum. You also have your right colic artery that will supply your ascending colon, your middle colic artery, which will supply the proximal two-thirds of your transverse colon. And then you'll have your IMA, which will give off your left colic to supply your descending colon, one to two sigmoidal arteries for your sigmoid colon, and then the terminal portion of the IMA is your superior hemorrhoidal or superior rectal artery. And then the branches of the SMA and the IMA have this rich anastomotic network via the marginal artery of Drummond that runs along the inside of the colon. And so we, as far as watershed areas of the colon, I would say the two areas that are most commonly tested are up at the splenic flexure, Griffith's point, and down here at the rectosigmoid junction at Sudeck's point. Just briefly going over some anal anatomy. So you have your internal sphincter, your external sphincter, and then your levator ani muscles coming up diagonally here. The dentate or pectinate line will start to is where you get the differentiation in your like histologic lining of the anal canal. And then when we refer to the anal canal surgically, this is the area that we're referring to, proximal to the anal margin, extending up to where your internal and external sphincters end. The distal anal canal is going to be aligned with your squamous mucosa, and then the anal verge right at the opening, and then the anal margin will extend out radially from the anal verge from this squamous mucocutaneous junction for an area of 5 centimeters. For the blood supply to the anal canal, so you have the IMA we talked about, where the terminal branch of that is the superior rectal artery. You also have some contributions from the middle sacral artery, and then off of your internal pudendal artery, you'll have the middle rectal artery and your inferior rectal artery. So a lot of redundant blood supply here. All right, so let's jump into some benign colorectal topics. So first up is anal fissures. These are categorized into typical and atypical anal fissures. Typical fissures are mostly located in the posterior or anterior midline, whereas the atypical ones can be located anywhere, but if you see one that's not anterior or posterior, you should think that there might be some association with a secondary cause, such as Crohn's disease, HIV, TB, a malignancy of the anus, or syphilis. With acute versus chronic anal fissures, with the chronic anal fissures, you may have these associated skin tags that you can see here. And as far as treatment, the first line treatment is typically supportive care with sitz baths, topical anesthetics, increasing patients' dietary fiber intake, and oftentimes up to 50% of the time, fissures can heal with just these interventions. If this doesn't work over a period of weeks, the next step would be to try topical nitrates or calcium channel blockers. These also work about 50% of the time. They can also recur 50% of the time. Of note, the nitrates aren't as well tolerated as the calcium channel blockers due to dose-related headaches. And then if these topical therapies fail, you can try botulinum toxin injection, and this works by relaxing the hypertonic anal sphincter that is leading to the fissure occurring. And then if all of these aforementioned therapies fail, you can offer an operative intervention, which is a lateral internal sphincterotomy, which is depicted here, where you actually cut the internal sphincter and then close the mucosa overlying it. Just have to be careful about this in patients who come in at high risk for incontinence to begin with. You want to avoid this type of operation in those patients because that can worsen their incontinence. And then for atypical anal fissures, it's important to know that you have to go down a different pathway of treatment, and you have to treat based on the underlying condition. If you just treat like a typical anal fissure, it's not going to get better. All right, moving on to hemorrhoids. So hemorrhoids are these vascular cushions of the anal canal that are a normal part of the anal canal. But with hemorrhoidal disease, these get engorged with stretching of the overlying mucosa or anoderm. And then over time, there can be loosening of the attachment to the underlying muscle fibers. And then this results in the hemorrhoids prolapsing out of the anal canal. You have three main hemorrhoidal cushions that are in the positions of left lateral, right anterior, and right posterior. Classically, we categorize these into internal hemorrhoids and external hemorrhoids based on their location to the dentate line. Of note, below the dentate line is more susceptible to sensations of pain compared to internal hemorrhoids. And then these are the different grades that you can see here. Bleeding but no prolapse, ranging all the way up to prolapse that cannot be manually reduced. As far as treatment, similar to fissures, non-operative management is the initial mainstay of therapy, where you can give fiber, stool softener, sitz baths, topical nitrates or calcium channel blockers if the patient has an associated increased sphincter tone. For grade 1 or 2 hemorrhoids, you can offer band ligation. That's commonly performed in a clinic setting. And if you have a patient that's on anticoagulation, sclerotherapy can be a good option if someone's on a blood thinner like warfarin, just because band ligation is associated with more bleeding. This could be a question that gets asked on the ABSITE. For operative and management, these would be the indications for someone with hemorrhoidal disease that could benefit from an operation. So persistent or recurrent symptoms that aren't responding to your initial medical treatment, internal hemorrhoids that are more than grade 2 and not amenable to banding, symptomatic hemorrhoids that have a large external component, and then any complications related to hemorrhoids like thrombosis, strangulation, or gangrene. And then specifically for thrombosed external hemorrhoids, classically the teaching differs depending on the time of symptoms. So if symptoms have started within the last 72 hours, the preferred treatment is a surgical excision just to get more rapid improvement of symptoms and having a lower recurrence rate. Whereas if the symptoms of the thrombosed external hemorrhoid has been present for over 72 hours, we tend to treat more with non-operative supportive care. All right, moving on to anorectal abscess. These are characterized into different types of abscesses depending on where they are relative to the internal external sphincters and the levator muscles. So perianal abscess, this is going to be your most simple abscess in the perianal space. It's superficial at the anal verge, continuous with the ischioanal fossa laterally. Ischioanal abscesses are located in the ischioanal space, usually below the levator ani muscle, and then the medial boundary would be the external anal sphincter. Of note, these ischioanal abscesses can communicate bilaterally via the deep postanal space, and this is called a horseshoe abscess. A commonly tested entity where your surgical management is a modified Hanley procedure where you open the deep postanal space, sparing the sphincters with a posterior midline incision, and then you have to open up these counter incisions on either side bilaterally to drain the ischioanal fossa. The other two common types of abscesses are the intersphincteric abscesses, and those are located between the internal and external anal sphincter muscles. And the superior supralevator abscess is located uh, ab- above the levator muscles. Medial is the rectum, laterally is the pelvic sidewall. All right. Similar topic related to abscesses is the fistulas that can be potentially associated with them. I'll go over the different treatment options and what they are and when are good times to use them. So for a primary fistulotomy, this is good for superficial fistulas, intersphincteric fistulas, and low transsphincteric fistulas. This is where you place a probe into the fistula tract and you unroof the tract along its length, typically with a bovie, using cautery. You want to avoid this in patients who have poor fecal continence, in women who have anterior fistulas, and in patients who have advanced Crohn's due to the high incontinence rates. Another treatment option is a ceton. This is preferred when you have a high transsphincteric fistula or a supra sphincteric fistula. Um, uh, or in the patients that we kind of mentioned before that are not good candidates for fistulotomy, those with like females with anterior fistulas and advanced Crohn's disease. And this is where a ceton that is loosely tied can allow for identification and definitive fistulotomy of the fistula tract at a future surgery. And the cetons typically promote fibrosis and allow for drainage, so an abscess doesn't reform in the meantime. More definitive treatments of fistula, I would say the two most common are the lift procedure and an endoanal advancement flap. So let's say you have someone with an abscess and a fistula, you drain it, you place a ceton, you get some fibrosis, and you bring them back to the operating room a month or two later, or several months later, and you attempt to lift. This is where you identify the fistula tract in the plane between the internal and external sphincters, and you actually ligate that fistula. Alternatively, you can try an endoanal advancement flap where you bring a flap of mucosa over the internal fistula opening, and this obstructs or blocks that internal opening of the fistula and eliminates the source of the fistula drainage. Typically, if you see answers on the ABSITE talking about fibrin sealant or fistula plugs, this isn't typically used just due to the high recurrence rates. Okay, moving on to diverticulitis, something that's very common. I feel like we don't use the modified Hinchey classification clinically very much, but just to briefly go through it, grade 1A would be kind of your pericolic inflammation phlegmon. A 1B would be your pericolic or mesocolic abscess. Stage 2 would be a distant abscess in the pelvis or other location in the intra-abdominal cavity or into the retroperitoneum. Grade 3 would be generalized purulent peritonitis, and grade 4 would be your fecal peritonitis. So breaking down an approach to the different stages. So for symptomatic uncomplicated diverticulitis, which is Hinchey stage 0 or 1A, important to note that if you do have a little bit of extraluminal gas or phlegmon on your CT, that this is not considered to be complicated disease, and you can just treat with antibiotics as uncomplicated diverticulitis. If a patient's hemodynamically stable, they don't have any complex medical comorbidities, and they're able to stay hydrated, you can give them oral antibiotics and outpatient follow-up. A lot of times as general surgery teams, we won't even see these patients or be consulted for them. If these criteria are not met, the best thing to do is admit, start antibiotics, fluid resuscitate, and then reinitiate diet under supervision. We typically track symptoms as we advance diet, and you can achieve non-operative management success in over 90% of patients. Important if you have a patient that's really not thriving after this treatment in 5 to 7 days. Important to repeat a CT scan to look for an abscess or evolution of the diverticulitis that may not have been present on the initial CT scan. All right, for modified Hinchey stage 1B or 2 diverticulitis, so if you have a small abscess that's not amenable to percutaneous drainage, typically less than 4 centimeters, you can just treat with IV antibiotics. This is successful 75% of the time at avoiding an operation. Again, similar premise, if you don't get improvement on IV antibiotics, try to repeat the CT scan 5 to 7 days after starting therapy to see if it's progressed to a point where it might be amenable to drainage. For large abscesses over 4 centimeters, we can usually get IR percutaneous drainage with IV antibiotics. And then once symptoms are improving, trying to advance the diet. If a patient worsens with IV antibiotics or percutaneous drainage, you may require an operation if you can't achieve clinical improvement with antibiotics and IR drain. All right, so modified Hinchey stage 3 or 4 diverticulitis with free perforation. These patients are extremely sick. There's a 30% mortality even with appropriate surgery. So really important tenets are fluid resuscitation, IV antibiotics, and emergent surgery. There's a few different strategies. So for a two-stage, the first one being a two-stage colectomy. So this is your Hartmann's procedure pictured here, where you do a sigmoid colectomy, closure of the rectal stump, and a proximal end colostomy. This would then be followed by an elective colostomy takedown 3 to 6 months later. The other option is to do a primary anastomosis with a diverting loop ileostomy as a second approach to a two-stage colectomy. These two approaches have similar morbidity and mortality, but a primary anastomosis with the diverting loop ileostomy has better rates of stoma reversal, almost 95% versus 60%. So if a patient is hemodynamically stable enough for a primary anastomosis with a DLI, that's preferred. A one-stage colectomy, this is a primary anastomosis without a diversion. It avoids the need for a stoma reversal, but this is really reserved for select patients who typically are not the ones that are going to be presenting with stage 3 or stage 4 diverticulitis. So I think the safest thing to answer on the ABSITE would be the Hartmann's procedure. Another important point is your post-diverticulitis colonoscopy. So 6 weeks after non-operative management for diverticulitis, it's important to get a colonoscopy because there is an association with colorectal diverticulitis and colorectal cancer and pre-malignant advanced adenomas, the rate you can see here. And so the CT imaging that you get as part of the original episode of diverticulitis is not sufficient enough to rule out a neoplastic etiology. All right, next we'll talk about lower GI bleeds. Initial steps, like any patient that's bleeding, getting appropriate IV access, type and cross transfusion, getting them into an ICU appropriate level setting. A large majority of these are due to diverticulosis, and 3/4 of bleeds due to diverticulosis actually stop spontaneously. Other potential causes can be angiodysplasias, which are most commonly seen in the right colon, ischemic colitis, which is usually due to reperfusion injury. Less common etiology would be neoplasia and hemorrhoids. So important to rule out an upper GI bleed first. Usually this can be done with an NG tube. And then as far as identifying the speed of the bleed, like ability to detect, the type of imaging modality or that can detect the slowest bleed is a nuclear medicine study, then CTA, then angiography, and the least sensitive would be colonoscopy. Treatment tenets would be IRM angioembolization, GI colonoscopy intervention, surgery if you have a large transfusion requirement over 24 hours, typically greater than 6 units. And if you do take them to the OR, the best thing is to try and do a segmental colectomy. There's poorer outcomes with total abdominal colectomy versus segmental colectomy. All right, let's move into some IBD. So we'll start with ulcerative colitis, which is characterized as a continuous inflammation from the rectum extending proximally. It's a mucosal disease only. Crypt abscesses are a buzzword that you'll see, as well as pseudopolyps. The extra intestinal manifestations include things like ankylosing spondylitis, PSC, uveitis, pyoderma gangrenosum. And notably, PSC and ankylosing spondylitis are not going to improve after colon surgery for UC. The pyramid treatment for managing ulcerative colitis starts with maintenance medications like mesalamine or infliximab, steroids for acute flares, and then 15 to 30% of these patients in their lifetime will eventually need some type of surgery. Important to note that there's an increased risk of malignancy from prolonged inflammation. So to surveil these patients, it's important to get a colonoscopy 8 years after the onset of disease symptoms, and then every 1 to 2 years following that. The way you get surveillance is with 4-quadrant random biopsies every 10 centimeters, as well as directed as biopsies of any suspicious lesions that you see. And then a common question that you'll see is you get a biopsy result of high-grade dysplasia or malignancy. Even if it's just high-grade dysplasia, the treatment would be a total proctocolectomy due to the field defect rationale behind offering them surgery with the high-grade dysplasia. For elective surgery, this is indicated in children who are having issues with growth, intractable disease despite maximal medical therapy, if patients are chronically steroid dependent, or like we mentioned before, if there is dysplasia or malignancies on biopsy. The treatment is a total proctocolectomy with an ileal pouch anal anastomosis. And versus an end ileostomy. And then if you have someone who presents emergently with toxic megacolon perforation or bleeding, you can offer an upfront total abdominal colectomy with an end ileostomy. And later you can bring down that end ileostomy and do a completion proctectomy with an ileal pouch anal anastomosis. All right, so moving on to Crohn's disease. As everyone has seen before, this is different from UC in that you have transmural inflammation characterized with skip lesions, most common in the TI. You can get it in any segment of the intestine. Generally, it spares the rectum. There's a bimodal age distribution of younger and older patients. And then you get sequelae of strictures, fistulas, granulomas, and creeping fat. These are some of the common extraintestinal manifestations. And then the pyramid approach to therapy for mild therapy would be your mesalamine and immunomodulator medications, whereas some of your more aggressive biologics like infliximab would be for more severe disease. For acute flares, you can give steroids, anti-TNF agents, or immunomodulators. And then for complications of Crohn's that require surgery, the most common would probably be strictures, as well as perforation, obstruction, cancer, or fistula. And this doesn't cure the primary disease. Something that might get asked on the ABSITE is which type of stricturoplasty you are to perform based on the length of the stricture. So for shorter strictures, a Heineke-Michelitz, which is a longitudinal incision, which is then closed transversely, is preferred. For medium length, 10 to 20 centimeter strictures, a Finney stricturoplasty, where you have a common channel in loop, is preferred. And then for large, very large strictures, you can do a side-to-side isoperistaltic stricturoplasty, which is the most complex. All right, briefly touching on C. diff colitis, which is in an anaerobic GPR organism. Notably, you can get it after a single dose of antibiotics. I've seen it happen with a dose of cefazolin that we give preoperatively. Treatment can be fidaxomicin for 10 days. Alternatively, you can get PO vancomycin or PO flagyl for 10 days. For first recurrence, fidaxomicin for 10 days or 5 days follow uh, sorry, BID for 10 days and then every day for the additional days listed. You can alternatively do VANC for 10 days. For multiple recurrences, you can consider a fecal transplant. And then for fulminant C. diff, VANC flagyl, considering rectal VANC enemas if there's an ileus associated with it. Surgery for C. diff is limited to people who have severe colitis that doesn't respond to medical therapy or develops a complication such as a perforation. You can consider getting to the OR if someone's increasingly becoming sick with increasing pressure requirements or impending signs of sepsis. And then the operation of choice is just a subtotal colectomy with an endoleostomy. All right, so volvulus, most commonly they'll ask about sigmoid versus cecal volvulus. Sigmoid volvulus is more common. It's in older patients. You'll often get someone who's in the nursing home on antipsychotics or a history of constipation. It's due to a narrowing of the mesenteric pedicle, which elongates and twists. And if stable, ideally we like to manage these with a flex sig with GI to detorse the bowel, and then a sigmoidectomy with a primary anastomosis while they're still admitted after you get a chance to give them some bowel prep. This is just because the detorsion has a high rate of recurrence. If you have concern for complications from the volvulus, like peritonitis, ischemia, or you can't detorse them with endoscopic decompression, then you have to take them to the OR for an emergent resection with an end colostomy. And then the classic abdominal X-ray will be kind of pointing upwards towards from the left lower quadrant to the upwards or the right upper quadrant. Cecal volvulus, less common, more in a little bit younger patients. Endoscopic detorsion is not helpful. These patients need to go to the operating room. Most typically, you'll offer a right hemicolectomy with a primary anastomosis, and your X-ray finding is going to show it originating from the right lower quadrant, pointing upwards towards the left upper quadrant. Colonic pseudoobstruction or Ogilvy's. Risk factors are patients who are on a lot of narcotics, have electrolyte abnormalities, have recent trauma or spine surgery, often elderly patients in acute care facilities. There's a risk factor for perforation when the cecum is greater than 12 centimeters or they've had a diagnosis for over 6 days. If you're not concerned about ischemia and the cecum is less than 12 centimeters, you can give supportive care and correct the underlying cause by correcting electrolytes, trying to reduce medications that might be causing it, bowel rest, decompression. If they don't improve, the treatment of choice will be neostigmine, um, where you typically want to have atropine at bedside due to the concern for a side effect of bradycardia. Um, can also consider endoscopic decompression if they're not improving. And then, as always, if you're concerned for ischemia or perforation, this would require the OR for resection plus minus a diversion. Okay, moving on to colonoscopy screening guidelines.
And
For a
then
normal
I think
risk,
we're running out
we're
of time.
going
So if you
over.
want to, yeah, so if you want to just try to get through some of these so we can get to breast as well.
Sure.
Sorry.
Sorry about that.
Oh, good.
I'll just briefly go. These are the different screening guidelines that are different for different types of risk factors. Um, for surveillance guidelines, if you have certain numbers of adenomas of different size, you'll have to it'll require different follow-ups for colonoscopy. This was something that I would definitely memorize for the ABSITE. There's usually a question each year. And then for colon cancer treatment, I'll just briefly go over this. For early stage T1 to T2 upfront surgery, stage two, uh, getting upfront surgery followed by adjuvant chemo, stage three, getting upfront surgery with adjuvant chemo, and then stage four, getting systemic chemotherapy. And just some brief principles. You want 5 to 7 proximal centimeters of proximal and distal margin. You want to harvest at least 12 lymph nodes, and typically no radiation involved. Sorry for going over. I'll stop there.
All right. Thanks, Dan. Yeah, it's amazing how fast the time goes when you're going through these. But I think the important things that were mentioned earlier were the perianal abscesses. Definitely know the differences between the upper GI and lower GI bleeds and their management, and then the differences between ulcerative colitis and Crohn's. Those are the mainly very commonly tested questions. And definitely look up pictures of the colonic volvulus, the cecal volvulus versus sigmoid volvulus, because they'll put up one of those KUBs and expect you to be able to tell which one is which. So, all right. So last but not least, we'll go on to Bailey to cover breast. Thanks, Bailey.
Yeah,
And sorry if we go over for a little bit, everyone. Hopefully we'll be able to get through all the slides here.
all right. And I'll be kind of brief. Hopefully, you guys can just kind of use these as a reference. You'll have access to them. So I'll go quickly here. So starting with some anatomy, knowing kind of the borders of the breast, but most importantly, probably the borders of the axilla, and we'll kind of get into that in the next couple slides here. As far as blood supply goes, just I would try to have a mental picture, mental image of this photo here, kind of showing the internal thoracic or the internal mammary artery, the intercostals, the lateral thoracic are going to be the blood supply. I feel like Batson's plexus is kind of always, it works its way onto the abscite as just this valvulus vein plexus that allows for hematogenous spread of metastatic disease from the breast to the spine. So that tends to be high yield. I think majority of us probably understand the lymphatic drainage of the breast, and 97% of that drainage, it goes to the axilla. Only 2% goes to the internal mammary nodes. And then Cooper's ligament, anytime you have a patient with dimpling of the skin or nipple retraction, is usually because of malignant invasion or involvement of the Cooper's ligaments. So these are just really nice photos, I think, displaying the anatomy. Very high yield slide, I would say, mainly kind of knowing the lymphatic levels and what levels we do with certain pathology. So um, looking at, you see the pec minor there, and the relation of the lymph nodes compared to the pec minor is going to be the definition of the level. So level 1 is going to be lateral to the pec minor. Level 3 is going to be medial, and then level 2 is going to be posterior. Um, as I listed there for breast cancer, if we do an axillary lymph node dissection, we only go for level 1 and 2, whereas in melanoma, you're going to go for all 3 levels. And I think that's an important distinction. And then, as you can see here, and I won't kind of belabor this, but very high yield to know the nerves of the axilla. Most importantly and most commonly injured is the intercostal brachial nerve, which causes paresthesia to the upper arm. So both in real life and on the ABSITE, I think this is very relevant when doing axillary dissections. Moving into benign breast disease, starting with some breast infections. So mastitis is classic. I feel like we all see this probably in the ED. You have inflammation and cellulitis. Most commonly is going to be a patient that's lactating, but there are also non-lactational causes as well, especially seen in smokers. The most common bacteria is going to be Staph aureus, and typically, they'll get an ultrasound or whatnot, and you won't see any fluid collection. So you treat these patients with antibiotics, warm compresses, and for patients who are actively breastfeeding, you just have them continue to do so. Also very high yield. I feel like it's a classic clinical, scenario where, the PCP has treated the patient for mastitis with antibiotics, and the erythema is not improving, and the patient hasn't gotten any better. And that should kind of trigger in your mind that this is possibly inflammatory breast cancer. As far as abscesses go, these are pretty straightforward. Typically, you'll see a fluid collection on ultrasound. The biggest thing to keep in mind with these questions is that you really want to start with a needle aspiration probably at first, especially in a lactating patient. If you do an IND on a breast abscess in someone who's lactating, you could promote a milk fistula. So trying to do a needle aspiration first, and then again with antibiotics and warm compresses and such. Duct ectasia, I don't think is super high yield, so I'll kind of skip over that, but essentially is just a form of nipple discharge related to smokers and is something to probably be aware of. Benign breast lesions continued. So the two at the top, fat necrosis and oil cysts, I think we all see pretty commonly in breast clinic. So fat necrosis is typically a result of trauma to the breast. They have, I guess the buzzword for that would be eggshell calcification. You can kind of see in the mammogram I added there that there's a round kind of calcified lesion, which would be the fat necrosis. And oil cyst just is a result of when that fat necrosis becomes like fibrous and kind of walled off. This is seen most often in the post-operative setting. Benign cysts or simple cysts. So these are palpable masses. They typically change with menstrual cycle or pregnancy. Simple cysts are well defined on the ultrasound. You can typically observe these. In some cases, if the patient's symptomatic or uncomfortable, you can aspirate them. Typically, I don't think we send these for cytology in real life, but certainly if there's some sort of concern or if you get bloody aspirate, you can consider sending this off for cytology. If there's any sort of atypia in the fluid, then that would be concerning and an indication to excise it. If these keep coming back and are bothersome, then excision is warranted. And then if there's any sort of solid component to the cyst, so it would be considered a complex cyst at that point, you would want to do a core needle biopsy of the solid part to make sure that there's nothing bad going on. PASH, again, I think is one of those probably not so high yield, but sometimes does come about. Typically, these are in premenopausal women. They're large palpable masses. There is no malignant potential. They're benign. Similar to fibroadenomas, you really only need to excise these if they're like enlarging or bothering the patient. Um, Fibroadenomas here, very common, most common in young patients. They, similar to cysts, will kind of fluctuate in size during pregnancy or menstrual cycles. They are rubbery, mobile, well circumscribed. The key here, kind of the take home for a lot of breast pathology is if you have a young patient under 35 years of age, you likely want to do an ultrasound to kind of work them up for any sort of breast mass. Whereas older than 35, you kind of want to default to a mammogram. These are both photos of fibroadenomas. The one on the bottom is just this like popcorn calcification of an involuting fibroadenoma, so they can kind of look different. So typically with these, unless they're symptomatic or enlarging in size, you can just observe these with like Q6 month ultrasound. If there's anything suspicious or if things aren't adding up, then you can do a biopsy of these. And specifically the giant fibroadenoma sometimes can be difficult to tell between those and like a phylloides, for example. So if they're really large, then usually you would excise those. Moving to phylloides. So there are multiple different subtypes of these, and it is based on atypia, mitotic activity, and just kind of the overall histology, stromal overgrowth. 10% of phylloides will be malignant, which is defined as 5 to 10 mitoses per high power field. They are typically large, like I mentioned. There are certain properties. They stain for vimentin and actin. They're leaf-like. I tried to add a photo of that. I think that's pretty characteristic. And they spread hematogenously, and that has implications for your treatment plan. We don't typically do any sort of axillary sampling in these patients. You do want a wide local excision of the tumor with at least a centimeter margin. And if it does end up being malignant, typically the patient will undergo adjuvant radiation. Mondor's disease is a benign superficial thrombophlebitis of the lateral thoracic vein. Typically, it's located in the like lower outer quadrant of the breast. As you can see in the photo, it's kind of like a taut cord-like structure. It is self-limiting. There's no risk of malignancy. Typically, you just have patients take NSAIDs and do warm compresses. I have seen in clinic just from strenuous exercise that people get these. So knowing some of these common indications, I think would be helpful. But ultimately, it's just self-limited. This is a busy slide, but the biggest kind of take home here is that if a patient's having nipple discharge, knowing that patients greater than 60 years old have 32% chance of that it's a malignant process versus 4% in younger patients. So age plays a really large role, as well as the worrisome features. So if it's unilateral, if it's bloody in nature, sometimes they'll describe it as serous, but typically I think bloody is what we'll see on the exam at least. And then if it's spontaneous. So those are kind of the things that point to a malignant process going on. Intraductal papillomas, I think a lot of us associate that with bloody nipple discharge. It is not a pre-malignant lesion. You can try to do a ductogram or ductoscopy, but that's kind of out of date. We now tend to just do duct excisions. You kind of go in the subareolar space and resect whatever affected duct and papilloma, presumably. This is a cool chart that I found that just kind of lists, there's several kind of physiologic, like brown and green, that you wouldn't necessarily would think would be normal, but is totally normal. So keeping that in mind as you're getting these questions. Moving on to some high-risk breast lesions. So radial scar and complex sclerosing lesions are kind of under the same umbrella. The difference is in the size, and this is on pathology. So radial scars are going to be small, less than a centimeter, whereas CSLs are going to be greater than a centimeter. They do have a characteristic kind of spiculating appearance on mammography, as you can see in the photo there. They can get a little confused with, it's hard to tell if it's a malignancy or not, just based on how spiculated and kind of irregular they are. So I think a majority of people still favor excisional biopsy. They can have an increased risk of malignancy. I think the literature is not entirely clear, but I think for all purposes of the ABSITE, you should excise these lesions. Another busy slide here. So I kind of broke up ADH is a pre-malignant lesion. It confers an increased risk of malignancy. You can have up to 20% upgrade rate to DCIS, as well as a 3% upgrade rate to IDC. So this needs to come out. And then you have your LCIS and your ALH. So these are not necessarily pre-malignant themselves, but they are a marker for increased risk for breast cancer and either breast. So I have some additional kind of things on here that you guys can review on your own time. Majority of the LCIS are going to be hormone positive. I do want to point out, if you have LCIS on your margins, you do not need to go back for re-excision. That's kind of one of the big pearls about LCIS, unless it's pleomorphic LCIS, in which you should treat it like DCIS, and you should re-excise those. Both patients with ALH and LCIS you can discuss chemoprevention with tamoxifen or some other form of hormone therapy for risk reduction. DCIS, so it is considered that you have malignant cells, but they're limited to the basement membrane. So very, 50% risk of invasive cancer in the ipsilateral breast. Does typically show up as calcifications on a mammogram. The Komodo pattern is kind of the highest risk. So if you see that, sometimes people will perform a sentinel lymph node just because of how high risk it is, and that you're more likely to find invasive component at the time of resection. Important to know, especially with kind of all of these, and I think I mentioned it, so as you review what your margins are going to be for all of these lesions. So with LCIS, we mentioned that you don't have to have a positive or you don't have to have a negative margin. For DCIS, you want at least 2 millimeter margin. If your margins are positive, you should go back for re-excision. Important to note, as far as your surgical plan, if you are going to do breast conserving therapy, which would include a lumpectomy, then that would also add adjuvant radiation to the plan. If you're doing a mastectomy, that's an indication for a sentinel node just because of how high the upgrading rate is to an invasive component. You want to get axillary sampling at the time of mastectomy because you can't go back and get it afterwards if you need it. And then similar to LCIS, you can discuss starting some chemo prophylaxis, as well as I think it's important to kind of note the contraindications, especially tamoxifen. Patients that have any sort of clots or hypercoagulability, May-Thurner syndrome, for example, could be a contraindication to starting a patient on tamoxifen. And then for anastrozole, osteoporosis is kind of the big thing to keep an eye on. All right. As far as kind of BI-RADS, I would commit this table to memory. They'll sometimes give you just straight up, this is a BI-RADS 3, and kind of base the question on that. So I think it's important to know. For screening purposes, annual mammograms, the NCCN guidelines recommend starting at age 40. Important to note that mammogram isn't perfect. And in patients that are high risk because of that, you typically will add an MRI. There are several genetic syndromes that patients are higher risk for breast cancer. We all know BRCA, Li-Fraumeni, Cowden, NF1, Peutz-Jeghers syndrome, and CDH1 are all kind of high risk for breast cancer in addition to the other malignancies. There are a couple kind of models and things that we can use to try to calculate risk for a patient. Typically, the Tyrer-Cuzick is more accurate. It accounts for more family history and the breast density, whereas the Gale model tends to underestimate family history. It just kind of does like mother, sisters, daughters kind of thing. So if patients have high or strong family history, then they're underestimated on the Gale model. I would also commit this slide to memory, just the TNM staging, remembering that breast is one of those that is size-based. 2 and 5 are kind of the numbers to remember for that. There are a couple specifics here in the T4s, such as inflammatory cancer, that by definition, those are T4D. And then, like many other cancers, the nodal status is going to be the most important prognostic factor. So here, I just kind of briefly review inflammatory breast cancer and Paget's disease of the nipple. So as we discussed kind of the stage there, this again can be confused with mastitis. So it's, warmth, erythema, the kind of orange peel change to the breast that I tried to capture in that photo there at the bottom, and kind of just engorgement and enlargement of the breast. Punch biopsy shows kind of this characteristic dermal lymphatic invasion, although it is a clinical diagnosis, so you don't have to have a punch biopsy for diagnosis. And the treatment for this is neoadjuvant chemotherapy and then a modified radical mastectomy. So that includes the mastectomy and an axillary lymph node dissection, and these patients are not candidates for immediate reconstruction. They do undergo typically chemo and radiation therapy. And then for Paget's disease of the nipple, it kind of presents as almost like a dermatitis, kind of eczema-like nipple changes, ulcerated skin. You want to work these patients up like anyone else to make sure there's no underlying masses with mammogram and ultrasound. This is one of the ones that they kind of have a specific histology finding. So the cells have clear cytoplasm and large nucleoli, as you can kind of see in that photo there. The biggest thing with Paget's disease is that 90% of the time it's associated with either DCIS or invasive ductal carcinoma. That is typically hormone negative. So it's important to kind of recognize this early on. And obviously treatment is going to involve resecting the nipple areolar complex. Kind of going over breast cancer, invasive ductal carcinoma, and invasive lobular carcinoma. So invasive ductal is going to be more common. It arises from the ducts. Typically presents as a mass or asymmetry, sometimes calcification on mammogram, and the margins for that are no ink on tumor. This is in comparison to invasive lobular, which tends to be a little more insidious, more difficult to see on mammogram, typically is not associated with calcifications. And so a lot of times you'll see people supplementing these patients with MRI just to make sure we understand the extent of the disease. But again, your resection is going to be no tumor on ink, or no ink on tumor. Couple kind of special cases here: male breast cancer and breast cancer in pregnancy. Male breast cancer is rare, associated with BRCA2, which accounts for 15% of male breast cancers. Patients that have a history of radiation and Klinefelter's disease. These patients need to undergo modified radical mastectomy for their treatment. As far as pregnant patients, so obviously we can't put them on any sort of hormonal therapy or give them radiation during their pregnancy. And also important to remember is that you can't use any sort of blue dye, so no methylene blue. We can just stick with the isotope for axillary mapping. In the first trimester, if a patient has breast cancer, your really kind of only option is a mastectomy with a sentinel node, just because of the timing of things. There are some chemotherapy options. I don't think you necessarily need to know what they are, but patients can be given chemo during pregnancy. If you're kind of in the later second trimester or the third trimester where they can get radiation pretty soon after their surgery, then you can offer them breast conserving therapy with the plan for them to get radiated after they deliver. And then just kind of reviewing some basic kind of surgical options. So partial mastectomy or lumpectomy is part of breast conserving therapy, which also includes adjuvant radiation. Contraindications to breast conserving therapy if you have multicentric disease, if the tumor is super large and you aren't able, there's just not enough breast tissue to accommodate a lumpectomy. Pregnancy, as we just mentioned, if the patient has had radiation previously, they're typically not a candidate for breast conserving therapy just because they're going to it would include radiation again, which is not typically something we do. And then any sort of like scleroderma or connective tissue disorders, we typically try not to radiate those patients. Modified radical mastectomy, I would just try to make sure you know the definition of this and what that means. It means that you're doing a mastectomy with an axillary lymph node dissection. And then reconstruction is probably not as high yield for us, but there are several options for your mastectomy. Obviously, if there's disease in the nipple or if the patient is a smoker, then you would not offer them a nipple sparing mastectomy. And then I think this is my last slide here, kind of going over indications for neoadjuvant and adjuvant. So if a patient has positive nodal disease, if they have a really large tumor and you're trying to increase and they want breast conserving therapy, or you want to increase resectability so that you can get negative margins, inflammatory breast cancer patients, and then there's a lot of nuance with the triple negative and HER2s, but typically those are the patients that are going to be getting neoadjuvant. As far as adjuvant, this is a part, like I mentioned, of breast conserving therapy, but for radiation, post-mastectomy, those are seen in patients that have several positive axillary nodes, if it involves the chest wall or the skin, if they have positive margins on final pathology, or if they had a large tumor. Typically, those would be patients that even though they got a mastectomy, we would still recommend that they undergo radiation. And then here I just kind of listed some of the common chemotherapy agents and their side effects, and then endocrine therapy as well. So I think that is all I have.
Awesome. Thank you so much, Bailey. There was one question, and it was, how big does the tumor have to be for it to be a contraindication to breast conservation therapy? And I don't think there's, most people would say about 3 to 4 centimeters, but I think the truth in real life is how big the tumor is in relation to the breast itself, right? Because
Yeah.
the goal is making sure that you don't cause breast sort of distortion. And so if most people will say, again, 3 to 4 centimeters. So if there's a question about that, that typically will be the answer. But in real life, you're looking at sort of the breast size in relation to the tumor size and deciding whether or not there will be a disconformity in the breast if you do undergo breast conservation therapy. And one thing you have to keep in mind and counsel patients about is the risk of coming back if you do have a positive margin. And so if you think about it, if you're doing lumpectomies and you have to come back, then you're increasing your risk of causing disconformity to the breast. So that really is what you have to keep in mind in real life. But again, the textbook answer there will be about 3 to 4 centimeters. Will they make it obvious if patient needs neoadjuvant chemo? Typically, yes. In my experience, yes, they will. Bailey, what do you think?
Yeah, no, I agree. It's probably going to be like inflammatory breast cancer or a really large tumor that would kind of clue you into that.
Yeah. So yes, it will be very clear if this patient needs neoadjuvant chemotherapy. So thanks, Bailey. I think the biggest things there are remembering the lymph node levels, the 1, 2, 3, and knowing that melanoma is the only one that requires level 3 dissections for breast cancer. Phyllodes, I think the question that I remember seeing a lot, or not remember seeing, but one thing that you should remember a lot is phyllodes tumors are the only ones that do not go to the lymph nodes, and so you do not have to do lymph node biopsies for phyllodes tumors. So that's a very commonly tested, both in real life and on the ABSITE. And then the high-risk breast lesions are very, very commonly tested. I feel like all the breast questions have to do with high-risk breast lesions. And I think the slide that Bailey had up is very, very helpful. If you can sort of go through that slide and remind yourself what is ADH, what is ALH, what's LCIS, those are all sort of the important things to know. Because being able to differentiate between those 3 or really 4 high-risk lesions is what's going to help you determine what to do for each one. And then the other contraindication for tamoxifen that we should remember is endometrial cancer. Obviously, patients who have DVTs, PEs, and things like that, postmenopausal women, high risk for coagulopathy, should not be given tamoxifen. So, and then BI-RADS, there will certainly be a question about BI-RADS on that exam. So you should definitely, like Bailey said, memorize that chart and really remember what BI-RADS 3 means. For instance, means they need to get a corneal biopsy. So important to think about about all that. I think we covered all the very important things. Are there any other questions? I don't see any other questions in the chart. If anybody has any other questions, please feel free to send them in the chat. But I think we've covered all of these. I did send a link earlier in the chat about the residence corner on the SSAT website. And just a reminder to everybody, this webinar will be posted on the website on the SSAT website under the residence corner page. I sent that link as well. I think it should be up in the next 1 to 2 days or so. So you can go back and review everything that we talked about today at your own convenience. So without further ado, thank you all so much for joining. I don't see any other questions in the chart. So thanks, Gilbert. Thanks, Bailey. Dan had to run because there was a major trauma he had to go to. But thank you all for joining. I really appreciate everybody's help today. Thanks.